Ladies and gentlemen, welcome to episode 17 of the Survival Project. Today, I'm joined by Dr Orlaith Kelly, consultant gastroenterologist and one of the strongest voices I've heard when it actually comes to advocating for people who are living with Crohn's and colitis. In this conversation, we get into the gap that can actually sometimes exist between patients and practitioners and why empathy and communication matter so much in chronic illness care. I want to say a massive thank you to Sol's Healthcare for making conversations like this possible and for creating apps like Osteat Connect. Chronic illness no longer has to mean isolation, and I'll tell you all about it later in the episode. So, let's get into it. Dr. Kelly, thank you so much for joining me today. The first time we met was at the Financial Burden of IBD survey launched by Crohn's and Colitis Ireland. And that day you spoke so passionately. I thoroughly enjoyed listening to you. What actually brought you into the line of IBD care, and I suppose what brought you to this point so far?
Thanks a million, Jonathan, for having me on the podcast this evening. It's such a pleasure to talk to you again. Yeah, so like as I said, we met at the Financial Impact of IBD meeting, and it's been a long journey towards advocacy for IBD patients. For me, I started my medical aspirations a long time ago when I was a young one. And medicine obviously was a career choice for me just because I'm a bit scientific in nature and wanted to be part of a caring profession. And gastroenterology came on board because of I suppose great teachers and just a variety of different aspects to practicing in gastroenterology, because it's quite practical, and then you get to meet lots of different types of people. But I've always been drawn to the inflammatory bowel disease space from an academic perspective because of the complexity, the problems that are there that need to be solved at a scientific level, but mainly because of the people I've met with inflammatory bowel disease over the years and have really driven that journey. Seeing positive outcomes has been hugely helpful to maintaining my hope and positivity as a practitioner. And I suppose also being aware, because I've been in this field for a long time, of how far we've come and how there's still quite a struggle for a lot of people, but that a lot of things have improved over the years as well. So it's my pleasure then just to help out in terms of trying to advocate for people at this point.
Yeah, it's great. I like, obviously most of the people I speak to are people who are with a lived experience. So it's great to have someone on from the practitioner side of things to give us a real look at how everything seems on the other side.
Right.
I know after I spoke, you mentioned that you felt emotional after listening to my story. How did those sort of personal encounters shape how you approach being a doctor in the gastro space?
Hugely, I suppose. Yeah, like I mean, one of the reasons I'm in it. But like your story in particular, I found very moving at the time, and I still do, I suppose, because you've had an immense struggle from a very young age. Like you've met all of these huge challenges as a child and an adolescent, and now in adulthood. And I just felt like your journey, the way you eloquently expressed it, and the kind of the stoicism of how you've dealt with all of these issues. It just really, it moved me personally. And then maybe as a mom, I felt for your own mother and all of the struggles maybe she has gone through to advocate for you through the years when you were too young to do it yourself. And now you're up on the stage, if you like, and you're advocating for other people, and you're just such an admirable kind of person. So I suppose, sorry, not to be overly praising your anything, but you know, really good.
My hat won't fit my head by the end of this.
But I did, so there was that, and the way you spoke was so impressive for a young person who suffered with all of these problems. For me, as a doctor, as somebody, as a practitioner, understanding the personal struggles of patients is really important, because that helps me to help you. Right. So if I'm doing my job properly, I have to understand where you're coming from. I need to know what your struggle is, what your problem is, so that I can provide you with the best care for you individually in that moment. So I think being involved with, patient journey is key, like to being a good practitioner.
Absolutely. And one of the main things that seems to be a kind of general theme is a lot of people would say that when they deal with practitioners, they sometimes feel a bit of a lack of empathy. And I think definitely attending these talks and different things is a great thing to see for us as patients, to see practitioners that they actually, they do care. They really, like, that's the reason they're in this job. That's the reason they're here to help us.
Yeah.
And sometimes I suppose for whatever reasons that go on, some people can feel like they're not being heard or not being listened to. So I really appreciate it when I do see practitioners who come to listen and be part of the patient journey and actually then share their own perspectives to kind of, I suppose, bridge that gap that can sometimes be kind of felt.
There is a gap, isn't there, sometimes? And I think it can very much, like you said, I think that the majority of people in the practice with chronic disease management particularly, they're really keen to help patients. But I think sometimes it's a communication issue, isn't it? That there can be a misstep on one side or another, or a misunderstanding, and then that can sort of set everything off on the wrong foot. So I find for me that empathy is the superpower. If you can listen to people even for the first 2 minutes of a consultation and hear what they're saying, that actually drives a really good consultation. So if I can manage that, don't get me wrong, I'm not perfect. I don't manage brilliant communication at every level. I've made plenty of missteps, and that's maybe why I try to be a bit more mindful now. But it's about finding common ground and building relationships. Because especially with chronic disease where you're going to see your patients over and over again, it's so important that there's a trust, that there's an empathy, that there's a relationship built. Because how am I going to convince you to take these terrible medications, sometimes with side effects, if I can't convince you of the advantages that they might bring to you long term? So we have to be on the same page. And as you said, I don't like, and we don't always succeed. And I think the pressures of the system for both patients and doctors, it's very and nurses, is very challenging, because you're often meeting in a time poor situation, or you've waited a long time, you're frustrated in the moment, and you're maybe not getting your point across the way you want to, or I'm not hearing it. And that can be where the struggle is. So I think like motivational communication is the big thing. And it was something I learned over the years, I suppose, but also through communication courses and skill things that I've upskilled myself in that area, because I feel like that's probably where there's a lack of education sometimes in medical school around that area. It's a weakness, but I think it's much better now than it would have been when I trained. But it's definitely an area that maybe some of the other social and healthcare professions do better. And I think that medicine is like half of medicine is about education and communication, at least, and the other half is treatment and knowledge. Those things.
Absolutely, and I suppose people can come in such a vulnerable sense, and then when there's a time pressure, that can almost seem like it's like the person delivering information is coming across as cold, but they could be up to their eyeballs. They have to get the information across because there's someone else they have to get the information
Yeah.
across in another 20 minutes. So,
Yes.
and I suppose that can where maybe the lack of empathy
I
can kind of
think
come
so. I
across.
think
And
it's often coming from a place of stress or urgency, from, that maybe they're okay, I need to get this message across. And it's sometimes then I think that can come across as cold. And it's not so much even the time spent, but it's how that time is spent. Because you can spend 5 minutes um, with somebody and help that and make them feel listened to, because you do actually listen. You hear what they're saying, what their motivation is, and that you're providing solutions to their problem. And then you can also, as a doctor, um, in the same moment, say, well, okay, I get it. You need this today. Overall, I think this is what we need to do long term to achieve what your wellness, and then you can kind of work together to get that without some of the negativity and the but no and wait a second, that sometimes happens.
completely, and I think unfortunately that's one of the big problems with the system is that it seems very designed for both parties to fail. It puts you under severe pressure. We're under severe pressure. Like
You
it's
said it,
just,
yeah.
it's yeah, completely. Like it's not helping anyone at the minute, and it's nearly like there's a sense of being like of being against each other when it's not
Yeah, it's
each other who's against each other.
right.
It's that the system is designed to not benefit anyone.
It's just, yeah, it's, as you said, you have to kind of, yeah, I think when you walk into the room, you kind of have to forget about the system and just be two people having a conversation. And like if you can build it that way, then it probably works better, doesn't it? If you can, but it's not easy to achieve, obviously.
Yeah, absolutely, absolutely. You mentioned in your talk, just when it comes to Crohn's and colitis, that only about 50 years ago could actually have been fatal.
Mhm.
From your experience, how far has the treatment come, and like what kind of breakthroughs might we be looking forward to in the future?
Well, I suppose there've been a lot of big steps and milestones, even in my own career span to date. As I said, there's still no cure for IBD, but there are a lot of advances. Like, when I look at it, I suppose initially we saw like advances in terms of surgical treatments in the 60s and 70s, where colectomies were life saving and provided a temporal cure for people with colitis. Now we have, I think, in the early 2000s, we saw the advent of biologic agents, or in particular anti-TNF or infliximab, which would have been the first one. And that really changed the landscape of treatment. So before that, you would have seen a lot of people who were on long-term steroid. And steroid was probably one of the only treatments we had for flaring of disease before the advent of these drugs, and then azathioprine and immunosuppression, all of which carry like quite a litany of side effects. And these medications were the first where you could really see a tangible change in the disease pattern, and where you actually provided mucosal healing or healing of the tissues in the disease. And I suppose I was around at that stage. That was my early career in gastroenterology, and you could see a big difference pre and post the introduction of anti-TNFs in how patients did. And really before that, it was almost entirely a very chronic illness with poor health outcomes in terms of your bone health, blood pressure, malnutrition, multiple surgeries, multiple hospitalizations. Whereas now that is thankfully less and less. I think nowadays then, like I suppose, is almost a third age where we now have a lot of other treatments, not just one class of agents such as suppress the immune system. And you're looking more now at that kind of early detection treatment of individual phenotypes or different types of diseases a bit more specifically. We're learning a bit more all the time about the causes of the disease.
I just want to circle back to you. You mentioned about steroids.
Yes.
It's a big conversation that comes up quite a lot, is the side effects. For me, steroids have always gotten me out of flares. They've been a great tool to really help me. Unfortunately, I have got some quite severe side effects from them, especially the lack of sleep can be quite tough. What would be the best way to mitigate kind of some of the symptoms that can come up when using steroids?
So yeah, I suppose it's a real challenge for you as a patient, and then also because they do work so effectively in terms of getting your flare under control. They're often used in an emergency situation. Now, I suppose as practitioners, we become more and more aware of the side effects of steroids and try to avoid them a lot more. I suppose you'll find, Jay, your IBD physicians are less and less likely to put you straight onto steroid now, or they will try you maybe with a steroid that is more topical. So either if you're suffering with colitis or proctitis, they might suggest using an enema rather than the oral agent. Sometimes there are some of the agents that are oral, but they are only absorbed in certain areas of your colon. So we'll sometimes use those type of steroids again to try and mitigate some of the side effects. So a little bit like if you have asthma and you use an inhaler, that you might use an enema or one of the topical steroids if the flare is sort of mild to moderate. And then also, again, that if you're using steroids, that it's an indicator to us, I suppose, as doctors, that we probably need to change your maintenance treatment, because it's a warning sign. And I suppose if you talk to like the kind of big guys in IBD, they will say like steroid-free remission is really the ultimate goal in terms of good management of your disease, because of all of these side effects that you can suffer from. In terms of what are the kind of serious side effects of steroids, I suppose we've mentioned sleeplessness or insomnia can be certainly one, and it can have other mood side effects. So commonly, sort of, it can affect your mood. And some people feel quite euphoric or a little bit high. Some people will feel quite depressed, and then I suppose it can exaggerate your mood. And for some people, there is a rarer side effect of steroid-induced psychosis, which if obviously is a complete contraindication to using steroids in the future, really, if that was ever to unfortunately happen to you. As I said, they are widely used. They're often something that GPs are familiar and comfortable with using, so they may prescribe them in a bind. I suppose the way they're prescribed is very specific, and it's quite a long course of steroids, so it again kind of puts you more at risk for longer term side effects like bone health risks, diabetes, high blood pressure, you name it, acne, obesity problems, and, so on. So there's lots and lots of different reasons not to use them. But again, they're still widely used because we don't have great flare treatments otherwise. Now, as I said, there are newer agents coming online, some of the biologic agents that work quite quickly. And so you might find that I certainly would push towards using those, especially if you've already had a course of steroids. We kind of go, okay, well, look, now maybe it's time to try one of these. And they can work quite effectively and quite quickly. But again, it's an access and availability thing. Sometimes the steroids are getting you out of jail, but it's a little bit like shooting a fly with a machine gun sometimes. So you're kind of trying to balance the risks and the benefits of it. So, but like once you're aware of that, if you are starting steroids, like if you are in a flare and your GP has started steroids, maybe just get in touch with your IBD team quite quickly. Let them know you've been started, so that hopefully you can try and prevent the next flare from happening by increasing your current treatment or changing to something else. It's time to act when you're on steroids, basically.
Yeah, definitely. And I know from my own experience, like when I knew when I was going steroids, I was going to have alleviation of the symptoms. I knew there
Yeah,
was going to
yeah.
be, I was going to be in better form, but I would get quite erratic, and like my family would be a nightmare to be around. I'd be like, just be aware that I'm on very high
Yeah,
drugs now at the minute. I'll be back to myself now in 8 weeks. And it
yeah,
wasn't the first or second time that we got that clarity that I had to be very vocal about so people would know what was going on with me.
yeah.
I think that's definitely one thing for anyone who's on steroids is to be
Oh,
very,
Huge
yeah,
issue, I'd say.
yeah,
Yeah, I can imagine because, like as you said, you're not quite yourself. I think, as you said, and it's not you, and like you can be probably on a short fuse. So it's really important to let your loved ones know I'm on medication. Yeah, you are annoying me, but it's not all you. I probably wouldn't be as annoyed if I wasn't on steroids. Right?
completely,
Yeah,
completely. The
yeah.
fuse gets very short. I know a recent guest, Sean Francis, described them as the devil's Tic Tacs, and it is just glued into my head. I'm like, yeah, that's a great
I'm going to
description of
start
them.
using that. That's definitely one to use. Oh my god, totally.
Like the education with IBD has come along so much since I was diagnosed. Like I'm diagnosed over 20 years ago. I recently interviewed a guy, Collins, who's an IBD researcher, and he blew my mind with how far we've come with understanding what goes on with IBD and the
Right.
triggers that might
Yeah.
cause it. But obviously there's still so much to go. We still don't, it's still idiopathic. We still haven't got a cure. There's still so much to go. From your experience, what are kind of the massive challenges you're seeing at the moment when it comes to treating people with IBD?
Oh, I think we still face quite a lot of challenges, don't we? I mean, you're aware of a lot of them yourself, aren't you? I suppose, as you said, there's no cure, and we don't have a clear cut, diagnostic pathway for most people. So that's your first challenge is getting a diagnosis, I think. So if you have symptoms that are suggestive of IBD, that it can often take quite a long time before that comes to the attention of even a specialist, between waiting lists or awareness, and the symptoms crossing over with other common problems like irritable bowel syndrome or celiac or so on. It can that can be your first hurdle to overcome. Um, the second big challenge that exists, I suppose, is then in terms of treatment and getting it right. So there's still, as you said, there's a lot of work being done on trying to individualize therapies because we have 150 to 200 different genetic mutations which are involved in inflammatory bowel disease. Um, Causality or etiology, and then there's environmental factors which aren't clear cut, and then activation of your immune system. There's lots of different areas that can be activated or involved, and that can be individual. And although we can spot patterns, we're not always 100% accurate as clinicians in being able to pinpoint what the best treatment for you will be first. So we're hopeful, looking at new research, that we will be able to pinpoint better using kind of AI, dashboard technology, better genetics, better proteomics, better microbiome analysis, that there will be, because it's not one size fits all. Sure, it's not. It's a different treatment for each patient. So we're hopeful that will improve. The other big challenge is then, I suppose, there's the physical challenges of the illness itself. You know, all of those symptoms that you face, like refractory diarrhea symptoms, urgency, incontinence, bleeding, anemia, the pain, the fatigue that can be overwhelming, all of the other symptoms that are outside of your GI tract, so ulcers in your mouth, skin problems, joint problems, all of those physical factors, which we hope that the treatments alleviate. And then alongside that, because you're all one person, we all are one person, I should say, and the psychological aspect of dealing with chronic disease, but and of dealing with all of these symptoms, the social aspects of how to deal as a young person with potentially, body altering surgery, to deal with how can I go out if I'm not sure if I'm going to soil myself, and so on. So like this massive psychological impact, and I think that is undertreated, not under recognized, but probably under resourced in Ireland. And then speaking of resources, the financial impact, which I suppose is how we met originally, is with that advocacy piece we're doing in Leinster House, that IBD isn't even recognised as a long-term illness on the long-term illness scheme, despite the fact that it's clearly a disability, despite the fact that there's 40 to 50,000 people in Ireland suffering with this condition. And that's like 1 in 100 people, which is common enough that you would think we should be able to support people better than what we do at the moment at a societal level. So I suppose there's all of these different levels of challenge. And I suppose, as you said, the science will meet some of that, But then there's the education and advocacy, and I suppose there's a role for government and society as well. So we all need to kind of step up and do a bit better.
Completely. I think definitely you coming on here to talk and sharing all the information is what's key going forward, so that we can get this recognised for the disability that it is. Because I would always say that Crohn's disease disabled my life way more than having an ostomy bag ever did. Crohn's disease locked me in my house.
Yeah.
Crohn's disease made me soil myself in public and embarrass my life. And so many times it was like, it was horrible. But the more I think back on what I went through, I think, how did I exist like that?
Yeah.
And Crohn's disease 100% did have that much of an impact in my life. The stoma bag allowed me to have a chance at life. Now it comes with its own problems as well. I won't say it's all.
Yeah.
I didn't find the pot of gold at the end of the rainbow. Things aren't as rosy as that. But to get Crohn's disease to be recognised as the problem that it is and not belittled by the current legislation is definitely something that
I
we're
think
all going to work on together.
I think that recognition, as you said, is key, and I suppose it's in getting that message out there is how we do that. Because I suppose public awareness of the difficulties, because I think a lot of people are not aware of the suffering, and I think there's a lot of misunderstanding amongst lay people about what Crohn's disease entails or what it is, and that maybe some misconceptions, because IBD and IBS sound very similar. So I understand that people misinterpret that, and it's so frustrating for me. So not to mind for you, it's very frustrating when people think, oh, sure, you just change your diet or whatever. I'm sure that happens to you a bit, and
just meditate, you'll be fine.
Yeah, right. And it's like, well, it's not quite, I suppose that, but
Yeah, might help a little bit, but it's not gonna. Yeah.
Exactly. You know, I'm all for mindfulness, but it's probably not going to cure the inflammation completely. So as I said, and doctors, we're supposed to be teachers, we're supposed to be educators. That's part of our role in society, I think, and I do feel kind of strongly about that. So I think public health concerns are all of our concerns, and particularly in healthcare. So I think helping to build that awareness, and I suppose hopefully through organisations like Crohn's Colitis Ireland, who are extremely strong in this area, I think, actually in recent years, and have some great voices, and just supporting that is really important.
Completely. Crohn's and Colitis Ireland are doing so much for people suffering with IBD in Ireland, and they're advocating for us daily, and it's great to know that there's someone on your side putting the things in place that we need to change people's lives, essentially. Because if this disease is recognised as it should be, it's going to alleviate a lot of the problems that people are suffering with. And one of the things that we know from the survey is the striking statistics that will show that patients are avoiding medical services due to cost, or they're skipping on medication. And for you as a clinician, I know for myself, like that's, you know you're going to have a problem, you start skipping what you need to do. But for you as a clinician, how hard is that for you to witness?
It's very difficult, because it feels a bit futile then if you're prescribing something if somebody can't afford it or they can't take it. There's no point in me giving you something if you're not going to be able to use it, or if it's going to cause you more stress and that's going to trigger a flare if you can't afford your medication, or if you can't make it to that appointment because you're going to miss out on work, or, you know, all of those hidden financial problems that happen when a bill needs to be paid so you can't afford your medication. And so it's it's heartbreaking in some respects, but I understand, like, we're in, you know, like, poverty is a trap for people, and it's known to cause ill health. I mean, that's part of why I suppose you try to have a social health care system, is to alleviate some of that. This isn't something that just affects the people on the edges of society. It's overall. There is a lot of problems. There's a cost of living crisis, and the medication costs are exorbitant in our jurisdiction, particularly. And I think that that's across the board. That's not just an IBD problem, but it's, I suppose, because IBD patients are on a lot of medication and a lot of stuff that isn't covered, that it becomes very, very acutely a problem for them once you're on over one or two medications. And, you know, you have to be quite specific sometimes with the meds, don't you? You know, it's brand specific sometimes because of where they're absorbed. So you can't substitute with cheaper options, or you're on supplementation, which isn't covered. You're on dietary things that aren't covered. So the cost adds up very, very quickly. And it becomes, I think the figures in the report were quite high, that people are paying out of pocket like well over $3,500 a year, which is no mean amount of money. money, for anybody. And that's out of pocket expenses. And then, as you said, it's so difficult for people with IBD to get access to disability payments or to get access to medical cards. And as you said, we're not part of the long-term illness scheme. All of those things are within reach if government funding allows for them.
Yeah, completely. And I suppose one thing from looking at the survey was that if you start skipping out on your medication in the now, of course that's going to lead to
Yeah,
poorer
a huge
health further down the
yeah,
line.
absolutely. Yeah, I
Could
mean
be
that's a really good
yeah.
point, Jonathan. Like it does. Like so, you miss out on a few doses, but that will ultimately lead to a hospitalization or to a steroid use, or potentially surgery. It'll definitely may lead to ED. So that all has implications for your life and your disease, and the damage that it will do to you personally, and also has implications for cost in the health service. So actually paying for these medications pays for itself if you look at it from an economic perspective, because if you allow people to be well treated, they use hospital services less, and that's far more expensive for somebody to be in ED or to be hospitalized overnight or to require intravenous treatments when they could perfectly well have been maintained on their medication should it have been paid for by the state. And I suppose that's where you're coming out. We don't have good data for that, so I suppose we need probably better. So we do a lot of good science research, but maybe we need to do a bit more cost benefit or economic research to back up these very clear anecdotal evidence there from patients and from providers that this is a problem.
Absolutely, we can be very aware of it, but I suppose if the thing isn't down likewise the survey, now there's undeniable proof of the financial impact of it. Whereas if we don't, I suppose, get these surveys done, there's nothing. You can't just come with a, oh well, we think this happens. Well, prove it to me, and then we might be able to do something about it.
And
So
I think
I suppose
that's how we have to approach it, isn't it? Yeah, just with harder evidence, maybe.
Just for a moment, I want to take a break from the pod to speak to you about Ostique Connect from Sol's Healthcare. One of the hardest things about living with a stoma or living with IBD can be the isolation that comes with it. I know from my own experience, chronic illness can be a very lonely place. I've been very vocal about the effect it had on me in my teenage years and how my actual fear of getting a stoma and living life with a bag nearly ended up me not being here today. If I'd had a way to connect with other people who were living with IBD or they were living with a stoma, I could have learned from their lived experience. It would have eased so much the fear of what I was going through. Connecting and learning from another is exactly why I started this podcast, which is why I want to tell you about Ostique Connect by Salts. It's the first ever peer-to-peer support app for people who are managing gut health conditions. So whether you've a stoma now, maybe you'll have one in the future, or you've had one in the past, Ostique Connect has a bespoke algorithm that helps you meet people from all over the world. People who've been on a similar journey to your own. So through the app, you can make supportive connections and you can have one-to-one conversations. It also gives you the chance to join forums and connect with a larger group of people. You can ask and you can answer any questions that arise. It's a great place to provide support in a safe space. And there's also helpful blogs and there's podcast episodes too. Ostique Connect by Salts is available to download via the Apple App Store and Google Play. So if you want to check it out, click the links in the episode description or simply search Ostique Connect. Thanks for listening. Let's get back to the episode. So I suppose the financial pressure can obviously lead to much poorer medical outcomes, which is overburdening an already overburdened system. So it's just exacerbating problem after problem after problem. The domino effect continues. I suppose as someone who's so immersed in the healthcare system and sees it on a daily basis, if tomorrow morning you could enact one change, what do you think would be the first step to take?
Wow.
No pressure.
No pressure. Well, look, I suppose, along the lines of what we said, I think I'd make IBD a long-term illness on the scheme and, allow better access for disability payments for people who can't work and so on, who have IBD. So that would be, I think these are key steps, just that I would take. I suppose you're looking then overall, if I could do anything, you're looking at maybe more timely access to investigations, to specialists, to treatment, because I suppose we suffer with waiting list problems, with access to ED, with under resourcing for staffing. So if I would double the amount of IBD nurses in the service. I would provide clinical psychology in every centre. I would provide nutrition specialists in every centre. And I would have obviously 5 of me in every centre, but but you know what I mean. Yeah, you per population, we're under resourced for what we are dealing with a lot of the time. So, for instance, in my catchment area, we've 1.1 IBD clinical nurse specialist with 3,000 patients on our books. And if you look at what's appropriate for through the NHS or European data, we should have 1 IBD nurse for every 500 patients that we have. And so we're clearly not meeting that. And we're not alone in this catchment. Every catchment is under resourced, I think, bar maybe one. We have a huge issue with staffing in the health service, and I think IBD is also falling foul of that. So again, not helped by policies like the embargo on employment that we've been going through, where we couldn't replace people who were lost in the health service. So you find the staffing fell off a cliff there for quite a while, and that has implications for direct patient care, including in IBD. That's
Of course, and like that
yeah.
is like just on a base level, it's ludicrous that you can't replace the people that leaves. You know, it just makes no
Yeah,
sense.
yeah.
And
Like logically to people on the front line, it makes no sense that these are obviously positions that are needed, but that has been, I guess, a money saving strategy for the health service for a number of years now. It's less enforced at the moment, but anyway, we
yeah,
are we are where we
that's a whole
are.
other conversation.
Yeah. Yeah.
Uh, from speaking to you, and like this whole podcast is about the lived experience of chronic illness, but obviously there's people like yourself who work in this sphere and see the cases every day and understand that it's a highly pressurized place to be in that isn't helped by the way the system is put up. Like, it's very easy to say, oh sure, you leave work and that's it, but it doesn't always work like that. What's the toll like on you personally? And obviously you're feeling it every day. How tough is it to be immersed in this system?
Well, thanks for asking. First of all, it's lovely to be asked how you feel. Being a medical doctor in general, has an emotional toll for most people because we're all human beings and we're empathetic people in general. So you're going to feel the pain, the misfortune. It's may trigger you a little bit in terms of your own life experiences or how you feel about different aspects of different care or different family dynamics that you meet. So I think you have, as a healthcare professional, every healthcare professional will meet that challenge. I'm very lucky in some respects. I have a lovely family. I have a great support system around me. I also have a husband who's a psychotherapist, but now that came later in life. But I think I have an understanding that to look after people, and you need to also be very emotionally aware of yourself. And as you said, it's not just about leaving it behind. It's sometimes about processing that and being thoughtful around, yeah, that was really upsetting and why that was upsetting. And, just understanding, I suppose, the psychology of our interactions with other human beings is important. As you said, how I deal with you and how you deal with me has an effect on both of us. Like it's not a one-way street, but to be a good practitioner, I do need to park some of it and be able to be professional and be able to carry on to the next case. So I might have one case where, I'm explaining to somebody that they have, maybe a terminal diagnosis. And then the next step is I have to go into the next patient who has something else. So you need good coping strategies. It's individual, I suppose. But again, it's something that I think in medical school is probably better dealt with now. I think in society maybe better dealt with now. You're less brush things under the carpet, more talk through things, but talk therapy, talking with your colleagues, talking with family about feelings, it's all like really important, and it helps a lot if you understand that you will feel some of the pain that your patients feel, and that's okay. The day you probably stop feeling it at all is probably the day to stop practicing medicine in the clinical sphere, because if I can't empathize, then I'm probably not doing my best job.
There's a human on either side of the desk. It's not just we're both here trying to
It might
navigate.
be an AI bot
Like,
in the future,
I actually saw a thing recently. Yeah.
But we're still a ways off.
Yeah. I know they did a test run on this thing called the Hippocratic AI, and I think they compared it to like there was two practitioners or whatever, and they compared the way the AI responded. And obviously, the AI is built for compassion and empathy, so it kept asking questions, being like, "Are you okay?" or whatever. Whereas a doctor, in a sense, isn't going to have time to keep asking these probing questions.
Cut you off. Okay, we're done.
Yeah.
Oh dear.
But it's definitely going to be a very changing world now in the next few years. So I think there will be massive advances.
And I think in medicine we probably have to embrace AI. It is going to be part of what we do. Like you can see it already in the technology. Like so in radiology and in endoscopy where I work a lot, we are kind of using AI to speed up the processes and to provide better diagnosis. So like I think you have to take the good with it. Will it completely replace the human side of interaction? I'm not sure. Certainly not in the extremely near future. I saw a program recently where they looked at AI in different spheres, and one of them was in the GP interaction. Now the GP still came out marginally better, in fairness teach them. And I think some of the nuances of a consultation were lost by the AI, but you can teach a machine to do quite a lot of things actually. So I do think, as you said, I think the future is going to be very different. So we might be having a very different conversation in 15 years.
I know we've definitely touched there on kind of the future of IBD care, but I suppose, how do you see the future of IBD care evolving? Is there, I suppose, hope for maybe prevention, earlier detection, or is there any kind of therapies that are maybe not so far away that are coming down the pipeline?
Yeah, I think there's exciting times ahead in a lot of ways. Like as we were kind of saying, there's been moves towards more direct care, more individual care. I was just talking to a researcher in RCSI today about some machine learning technology, like we were just talking about, which might help with sort of better and more acceptable technology for diagnosis. So there's a lot more non-invasive methods now to look at IBD, whereas when you started out, endoscopy probably was your only way to look at the bowel, whereas now we have other methodology like intestinal ultrasound, capsule technology, maybe fecal calprotectins and other non-invasive markers that are very accurate now. So I feel like that's a bit more acceptable in terms of how we monitor people. Then we have studies looking at early disease. We have studies looking at precursors of disease, I suppose, in genetically predisposed people. And those are very interesting. So I think you see Intercept is one study that's ongoing at the moment. And then there was previous studies in Canada where I used to work looking at the predisposition to Crohn's disease and what the bacterial composition is and the genetic composition for these patients who then go on to develop Crohn's disease. So there's lots of work out there where you can kind of see little wisps of how we might practice in the future. And I sense that we will have some kind of an inputting system where you'll go, okay, this patient has X, Y, and Z genomics, proteomics, blood work, symptoms, and then it'll do some kind of a calculation and you'll say, okay, they are suitable for X treatment or Y treatment, and that might make things a little bit less haphazard, a little bit less witchcraft than it currently is, I suppose. And that, because the frustration for a lot of my patients who are complicated is in terms of that the disease is complicated rather than them, I should say. They've been through a lot of treatments and maybe none of them have worked, and that's very frustrating when you have very bad disease and you've been on the best treatment, but it hasn't worked for you. And there are reasons why you might not respond, but we're not clear on what those are yet.
I know from speaking to people like yourself and hearing how the knowledge has changed so much since I was diagnosed is night and day, completely different. Like I remember when I was first diagnosed, my mother floated the question about diet, and it was like, no, like it was categorically diet has nothing to do with it. Now there's more of a talk about the individuality of it, whereas we understand that, if it wasn't individual, we'd all take infliximab, we'd all be fine. We wouldn't be here having this conversation.
Exactly. We wouldn't be here.
Yeah, exactly. If only it was that simple.
Yeah. That'd be great. No, but it's, as you said, it's individual, it's nuanced, and diet can mean different things for different people. And as you said, for some people it's a treatment actually for especially in the pediatric population. We tend to use enteral nutrition, or for people who have fistulating Crohn's disease, it can sometimes be a very good treatment. And then we talk about, are there causative factors in our diet? Well, we don't 100% know, probably not, but there are certainly things that are protective, or there are certain diets that seem to work better. So like the general advice, I suppose, just for people who are listening to the podcast with IBD, if you're well, is the kind of Mediterranean diet with all the colour on your plate is probably still the best studied and most reliable diet. So where you're getting a little bit of everything and plenty of nutrients. And then it just depends then on your disease type. Like if you have narrowings in your bowel, you're going to be avoiding a lot of insoluble fibre. Whereas if you're in the middle of a flare, you're probably going to lean towards more bland food and slightly less soluble fibre and things like that. So it can be very nuanced, as you said, and it can be different for you on a different day. That's probably one thing to just remember, that when you're flaring, your diet is probably going to need to change a little bit just in terms of managing your symptoms. Whereas when you're well and feeling good, you can probably eat most things, and there are certain things that will probably always affect you though.
Completely. In my own cases, like when I'm good, I can drink coffee. I can have 2 or 3 cups. I
Right.
won't be
Yeah.
burping. There'll be no adverse effects. I know if I'm in a flare and I have a cup of coffee,
Yeah.
I am just poisoning myself.
Yeah, it's a bit like, yeah, and it's completely understandable because your system is activated and caffeine is going to stimulate it further, isn't it? So, and I love a cup of
Really,
coffee, so I really
oh,
empathize with
same
people
as.
when they can't drink the coffee.
Absolutely. I,
Yeah.
I, I know anytime I've gone on a strict diet, the only thing that I'm waiting for by the time maybe the strict diet is I'm just dying for that cup of coffee and I'm nearly dreaming about it. So I suppose we get a bit fixated on the things we can't have.
Well, that's it. You do, but like that's human nature, isn't it? Right?
Yeah,
Yeah.
absolutely. I know we've spoken on there about some people who might be quite frustrated with treatments, things aren't going their way. If there's any advice you could give to someone who's kind of in that position now where they've tried a couple of treatments, they're still experiencing symptoms, they're getting really frustrated and they're not very hopeful for the future. Is there any advice you could give them?
Keep advocating for yourself in that situation and come back and say, look, this isn't working for me. I feel like we need to do something different, and have that conversation with your team. If they're not fully listening to you, have it again. Get somebody else to have that conversation with them, with you, maybe like bring somebody with you and say, look, we've tried these things and we're really wondering where are we going here. And I think for the majority of people that will work, or, if you're in a very complex situation, I will often seek a second opinion from my colleagues as well, just to say, look, we've tried this, we've tried that. What do you think? There are always there are a lot of options now where there wasn't any. So it may be that rather than flogging a dead horse, there might be a new treatment or a relatively new treatment or a different pathway that you might be reaching the end of the road in terms of medical treatment, but that doesn't mean that dietary management or surgery aren't options for you. And then, of course, there are trial treatments available as well. So if you're in a centre where they do research, like in any of the university hospitals, will do research as well. And I suppose in terms of new treatments, so you might have availability of a novel treatment, even if you have been through 5 or 6 other biologics, there might be something else out there that might work for you. It's challenging in the extreme when you're in that situation, because with each treatment, your risk of failure is much higher, because obviously you're on that very top end of the spectrum of severity of disease. And it's important to find mental health supports in that context as well. Like, as you said, it's hugely demoralizing to keep coming back and not have a result, and not have a cure, not have a quality of life. And then it's trying to manage that in the moment, and then in the medium to long term, while you're seeking better physical options. It's so important to keep on top of that as well.
Absolutely. And I suppose I know that this next question might have a few parallels in the answer to the last question, but for someone who's just been diagnosed and they're just really worried, they're kind of seeing a lot of stuff online, they're not too sure what the future is going to hold for them. Have you any advice for them?
Oh, it can be a scary place, right? And when you're newly diagnosed with a condition, you're not fully aware of what the consequences would be, and your doctor probably isn't going to be able to tell you exactly what's going to happen. So that can again just breed uncertainty and fear. So I'd say in that context, I think reaching out to like websites like the Crohn's Colitis Ireland website, actually, which is very useful, looking for support in that social network of people who've been through something similar, can be very helpful. Seeking the support of the IBD nurse in your gastroenterology unit is probably really helpful too, because I think though they're not officially psychotherapists, they do a lot of counselling on the phone. They can talk you through a lot, because they have that lived experience of dealing with people who've gone through this a lot, and sometimes even that can be really helpful and supportive, and educating yourself on the condition. So there's lots of material available. And as you said, sometimes you can go on Google and go down a rabbit hole and scare the bejesus out of yourself. But if you, like, the majority of centres will provide you with good links or good websites that you can go on and look at reliable information. And then, so I would suggest, as I said, the Crohn's Colitis Ireland, really good. Anything that your healthcare provider gives you, usually very good. And then if you're looking for websites, Cleveland Clinics do great information in really good lay terms. It's a bit American, obviously, but it's really well explained. So if you're looking for information on lots of different things, the Mayo Clinic, Cleveland Clinic, they provide lots of lay information, which is reliable as well. And then ECHO, which is the organisation for European Crohn's and Colitis Ireland, is I would always recommend healthcare providers to go on and look at the guidelines. But if you're interested in the science behind the disease or how practitioners think, it's always a good website to look at as well.
Yeah, I think arming yourself with knowledge is armor. You're making yourself
Knowledge
stronger.
is
You know
power.
what?
Yeah.
Yeah,
Yeah.
completely. That's what I was working towards. I couldn't think of the word, but
It's the one.
yeah, because
Yeah.
I know for me, it's only in the last couple of years I actually know what my blood results mean. Like, because obviously, as we mentioned before, my mother was always advocating for me. I left that information to her, but knowing what the little things mean, like the CPR and all these different things, and even knowing what calprotectin means, these different things were something that I'd heard the words, but I always kind of just thought, oh yeah, it's something to do with Crohn's. Whereas now, in the last decade, I've had to really learn what these things actually mean,
Yeah.
so I can understand what the practitioner is telling me and what my results will mean. So I think definitely arming yourself with knowledge is great advice.
Oh, definitely. And I think it gives you a sense of control as well. And the other thing is, I suppose, as we enter into an age of remote monitoring, you might actually be looking at these things yourself at home. You can test at home and you can see the pattern, go, oh, look, my calprotectin is rising. So I'm going to do this and I'm going to contact, because there's a lot of stuff that can be self-directed in the right hands. And I think that gives you back some of the control of your illness as well, which I think is really important, that patients feel that they're in charge, because at the end of the day, you're the only person that really knows how you feel.
Definitely. And could you just speak on that ability to kind of test at home? Is that something that's kind of becoming more of a mainstay in IBD care?
It's becoming a bit more commonplace now. It's still not as widespread as it could be, I suppose, but there are a lot of different remote monitoring techniques that are coming online. I think that we will see over the next few years. And I think with apps and technology, it's becoming much easier to communicate from a remote place. So you see in other medical specialties, like in respiratory medicine, that they've done this through COVID, and in monitoring people's oxygen levels and so on at home. So the type of things that we would be monitoring would be things like your heart rate variability or things like that, which is kind of very much in the research stages in IBD, but there are some good papers on it in terms of prediction of flare. And then you have things like measuring your calprotectin at home. So there are home kits which are available through some of the companies, and you may be asked to do them, and that can be a nice way to do, like, especially if you live far away from the hospital. I think it'd be a nice way to be able to manage the disease, where you could do the test and have a quick phone call with your IBD nurse or doctor, and they can kind of say, okay, well, these are your symptoms. Calprotectin pattern is going up, so we're going to send you a prescription by email. It might just make life that little bit easier in terms of travel and accessibility. So yeah, look, I'd be a fan of it if once they become more widely available and easily usable. And so I think that still needs to be cracked completely, but
definitely it's a move in the right direction and gives more power back to the patient, where I suppose they wouldn't have to be sending emails or making phone calls to try and figure out information.
That's kind of the last thing you want, is you have to be chasing up on things and that. Whereas if there was an easier system where there was like maybe a ping, an alert in the IBD office that Jonathan's calprotectin is going up, we'll give him a ring or we'll email him.
Because even I wear a Whoop monitor, and the last time I went through a flare, my HRV absolutely tanked. It was the first time I'd really understood that there's a direct correlation between it. Like, so it was great for me to see that. I was like, oh my God, there are measurements to take in the body here that you could arm yourself with knowledge to hopefully prevent maybe going forward. So definitely moving into the more wearable space and
because
the newer
wearable technology is so widely available now, because lots of people are using it for fitness, for steps, for sleep, and so on. So like it makes sense for us to use it then, if there is, and just I suppose it's looking at those correlations. There was a paper in Gastroenterology relatively recently looking at it, I think from Mount Sinai in New York. So there is definitely promise in that area. So yeah, watch that space for sure.
Yeah, and recently I've been contacted by different IBD apps that are for tracking food and tracking your stool and your movements and stuff like that. For if someone was to come in with you with detailed information of, say, the previous 3 months since their last appointment, does that make your work a lot easier?
Sometimes, yeah. I would say in the main, yes. And I suppose in the right hands, yes. And then I think sometimes, obviously, you don't want to get too obsessed with things either. But like it's, but I think in general, yes, very good information, because then you have numbers. You know, you have graph or whatever, and it's much easier for everyone to understand objectively than what's happening, because it's, you know, you've tracked your diet, you've tracked your bowel motion frequency. So yeah, it can be very helpful.
Technology is moving us in the right direction to have a more understanding of what's going on in our bodies, and that definitely the knock-on effect has to be we get healthier as a whole. So fingers crossed anyway.
Yeah, I think so. Yeah, and you can see the same things like in other areas of medicine, like with cardiology, I think as well. Like using blood pressure monitors at home now would be very widely used where they mightn't have been 10 years ago. So you can even do ECGs and stuff at home, which would have been unheard of like 10 or 15 years ago as well. So all of this technology, as you said, you mightn't love it, but I think it's part of the space now, and you kind of have to embrace the good side of it and how it does help to empower people to be at home and be healthy at home and hopefully prevent disease at home.
Absolutely. We'll all be kind of half cyborgs going forward anyway, so there'll be no problems there. Is there any particular point you'd like to make? I know I've been throwing questions at you, but is there anything you'd like to share yourself?
For people who are out there who are worried that they might have IBD, maybe we should talk about that for a second. So
absolutely.
If you're concerned about your symptoms, or the kind of symptoms you might have if you have IBD, would be diarrhea that lasts for more than a number of weeks. That being increased frequency in your stools over 4 to 5 times per day generally, and loose nature. You may have rectal bleeding, you may have pain, but IBD is not always specific to those symptoms. There are other kind of more unusual symptoms that can happen. So fatigue is a huge symptom for lots of people, joint pain, mouth ulcers, we've mentioned, some skin manifestations, because it's a systemic illness. If you're worried about these things, or if you have a family history, or you're thinking something like that might be happening, do visit your doctor and mention it. There are some simple tests that they can do, like including blood tests and stool tests, which can help to guide your diagnosis and hopefully get you on the right track, because the earlier that we can detect problems, the earlier that we can see you, the better we can treat you going forward. Early detection, as we keep saying, is key for lots of illnesses, particularly for reducing digestive damage over time for people with inflammatory bowel disease.
Completely. I think one of the wisest things you can do is not ignore symptoms. Like, early intervention is key to finding the issue, and it's definitely something to get across, because I know we can be so busy in life. We're like, oh, look, I'll worry about that. I'll worry about that. And then you're almost afraid to check it out in case there might be a real problem. You like bury the head in the sand. But
I know,
no, it's definitely great advice.
It's just to be proactive. And if you're worried, if you have had a worry or a second thought about symptoms, to try and get it checked out. And I understand that the accessibility isn't always as it should be, but do make yourself go and get that checkup if you feel like you have something that isn't normal. And we'll try and see as soon as we can.
Okay, yeah, absolutely. I suppose I'm going to hit you with a bit of a zinger now, just to finish things off. So, a question that I tend to ask most of the guests. It gives me a great insight into the people. But what on a daily basis, what does happiness look like to you?
Oh my goodness, you're so deep.
The stoicism's coming out there.
I love it. No, that's a great question. So yeah, on a daily basis, well, I'd have to say my kids probably are my happiness, and my husband, and my dog, and my 2 cats. So they're the mainstay. But I suppose you find happiness in moments, don't you? I think it's important to just, enjoy that little bit of sunshine on your face, or listening to the waves, or whatever little simple thing, just to enjoy the moments. That's I think where I find most of my happiness.
Oh, completely. The power now, living in the moment as opposed to living in the future. The future is anxiety. The moment is now in peace. So yeah, that's great insight. Thank you very much.
I could do with a little bit more of that, I think.
Yeah. We all could. You have a psychotherapist at home to help you out. It's great.
Oh, well, I don't know. I think he likes to leave that behind.
I was going to say, doesn't want to be doing that at home. No, Dr. Kelly, it has been great today, and thank you so much for your insight. I really appreciate your time.
No, thank you so much for having me.
Absolute pleasure. Thanking you.
Best of luck with all of this. It's fantastic.
That was episode 17 of the Survival Project. Thank you so much to Dr. Kelly for coming on and sharing her insight. If you're listening and you're newly diagnosed, or you're in that tough phase where treatments aren't working and hope and feel thin, keep advocating for yourself. Keep asking the questions. As Dr. Kelly said, bring someone with you if you need to. Use reliable resources. It's so important to learn what your markers mean, and also to stay connected to support networks like Crohn's and Colitis Ireland. Again, a massive thank you to Sol's Healthcare for helping to make this possible. If you'd like to check out Osti Connect, you can do so by searching Osti Connect in the App Store or Google Play. I'll have download links in the description. Thanks so much for tuning in, and I'll see you next week for episode 19, which will be with Namara Wild, a transformational hypnotherapist, who I myself have actually seen the power of her work, and I'd highly recommend tuning in. Thanks for listening, and your support as always. Hope to see you next week.